Hello, I'm Wayne Strasser. Thank you very much for your interest in our work on COVID-19 transmission. We're focused on mitigating the movement of COVID-19 or any airborne contagion in hospital rooms. I'll briefly go over this today. It's predominantly been the work of my graduate student, Reid Prichard, and we've worked in collaboration with Scott Leonard at Vapotherm, as well as our respiratory therapy program here at Liberty. We aim to evaluate the efficacy of the FelixOne apparatus, originally proposed by Felix Kusid of New York Presbyterian Hospital. It consists of a standard oxygen mask, but instead of oxygen mask being delivered in the traditional sense, such that oxygen is being given to the patient, in this case the mask has been attached to a standard hospital vacuum system that will pull a mild flow of approximately 30 liters per minute through the mask. Shown here in the picture on the right is Vapotherm's realization of this design that has the mask as well as their high-velocity nasal cannula flowing at different rates depending on the patient's needs. This apparatus has multiple advantages. It's inexpensive, it's reusable and standard in many hospitals, and their preliminary testing at Vapotherm would indicate that the FelixOne is even more effective than a fabric mask. And in contrast to a typical fabric mask or a disposable mask that are uncomfortable due to heat buildup, this mild flow of mild flow of air coming around the patient's face and into the suction gives a nice cooling effect. I'll briefly outline our methods. We use the commercial CFD package, Fluent 2020 R2, run on a Microsoft Azure cluster of 2,160 CPU cores, 8.5 terabytes of RAM. I will speak more about the Microsoft cluster in a moment. Our domain can be described as a single hospital room containing 2 supine patients, each assigned 2 caregivers, the associated room HVAC, and some furniture. Each patient is wearing the FelixOne apparatus, which again consists of a standard hospital issue oxygen mask with Vapotherm's high-velocity nasal cannula. For boundary conditions, we have realistic breathing, which I will discuss more detail about in a moment. The high-velocity nasal cannula is delivering oxygen at 40 liters per minute. The oxygen mask is involving a suction at 30 liters per minute. The room HVAC is aimed in a starting condition from top down. We can try multiple conditions, but this is where we've begun. And the volumetric flow is representative of typical expected hospital room turnover rates. And again, we do plan other permutations. Our discrete phase model representing the motion of the COVID-19 particles, or sputum. We are tracking approximately 1,600 particles for up to 10 minutes. This is for the steady particle tracking models. Each patient is emitting 16 particle size classes, and that mass and size distribution is based on expected values. Each patient has those 16, making 32 total, and we also have tested some unsteady DPM, which I will show a preliminary animation from in a moment. Shown on this slide is an example of our mesh resolution. This view is taken along a patient center plane where you can see the high resolution polyhedral mesh around the patient airways and the mask. The mask is outlined on the left-hand side, the sinus is on the right, the airway inlet on the bottom left, and the nasal cannula in approximately the center. We cannot see the nasal cannula jet entering the patient's nostril because that is off the center line of the patient. But illustrated here again is the resolution around the patient's airway. The mesh is a mixture of hex and poly for a total of approximately 130 million elements. The mesh count before conversion to poly that was based in tetrahedral for the unstructured regions was over 300 million. Shown on this slide is another view of the patient centerline mesh. This view, however, is farther out from the previous view. Illustrated here is the fact that much of the room can be blocked and meshed with either structured or unstructured hex regions. This allows us to maximize accuracy as well as minimize cell count. An interesting feature of our work was the desire to optimize our run conditions and machine count such that we would get the most iterations possible for the allotted Azure grant given to us. So we proceeded to a multi-objective optimization to look at speed and cost. We ended up running on 18 machines, which is 2,160 cores, but we did not begin that way. We have effectively unlimited access to Azur's HB120 RSV2 machines, each having 120 AMD 7002 cores. We tested our model, however, on 1 through 36 machines, and we developed a cost metric that is going to be in terms of dollars of funding per million cells per million iterations. Now, for those of you familiar with the costs of MPI and overhead of distributed machine cost, etc., you would expect one machine to be very efficient. In fact, one machine in our test was the most efficient at $124 per million cells per million iterations. That was followed by 3 at 151 of the cost metric. 2 machines was even less efficient at 217. The major exception to our analysis was 18 machines. It was a very interesting local optimum in terms of our cost metric and runtime. The plot below illustrates our findings. On the left-hand axis is our cost metric. Again, that is dollars per million cells per million iterations, where down is more efficient. On the right axis is the runtime in terms of second per transient iteration time, transient time step, and that is where down would be better, lower seconds per time step or per iteration. The interesting feature of this is we found that, again, that 18 was a local minimum. As we look, the blue dots represent the cost metric versus machine count. You can see that 1 is the lowest, and then 3, and then 2 is actually higher than 3, as previously stated, and then moving on to the right. Whereas the time metric, shown in the red dots, and the trend line is across the bottom. 18 machines turns out to be an optimum situation that minimizes the cost and also minimizes the time. 18 machines is not the least costly because the cost metric is 181 compared to, say, 3 machines, which is 151. But it turns out it's 5 times faster than 3 machines while only being 17% less efficient. So we ended up running all the permutations on 18 machines, which is 2,160 cores. A snippet of our breathing curves is shown here. While our model has 6 people breathing independently with 6 independent breathing curves, we are only showing 3 here for simplicity. These are anatomically correct, as you see the asymmetric inhalation and exhalation. Each person has unique respiratory rates. They have randomized inhalation, exhalation amplitudes, breath per cycles, etc. We generated these under the direction of Dr. Brian Walsh, head of our respiratory therapy program at Liberty. We want to point out a few things from the plot. We see that the randomized amplitude for person 3 is outlined here, so that between their first breath and their second breath, there is a different amplitude again, both on inhalation and exhalation, and that's a randomized pattern built into our user-defined function in Fluent. Here is a brief animation of one of our transient particle simulations. It illustrates that we have anatomically correct and detailed airways given to us in CAD files by Vapotherm and developed from medical imaging. The value of the anatomically correct airways is to be able to produce a boundary condition in the mask region that is representative of the turbulence quantities and velocity distribution leaving the nose and the mouth. It also allows us to correctly proportion flow between the nose and the mouth based on the position of the mouth. In this case, it's fixed, but of course that can be varied for future studies. The interesting finding here is the strong influence of the high-velocity nasal cannula on the amount of particles getting into the nasal air passages. It can be seen that most of the particles leave the patient's mouth and get pulled out of the patient's mask, but there are a number of the smaller particles leaking in the room, and we will discuss the mask efficacy in a future slide. Before getting into quantification metrics of our mask study, I'll illustrate the overall layout of our room. Patient 1 is in the background. Caregiver 1A is near patient's waist with the phone in his or her hand. Caregiver 1B is at the patient's feet. Patient 2 is in the foreground. Caregiver 2A is at the patient's midsection, where caregiver 2B is in the patient's feet. Each of the caregivers has a phone, and these particle streamlines are just indicative of residence time, and the quantification of this is irrelevant, but it's important to know that darker is less residence time, as would be expected, as the darker colors are close to the patient's faces. On this slide, we focus on the effectiveness of the mask, which is our primary metric of the study. We gathered particle data on all surfaces, including caregivers' phones, their airways, etc. The data were aggregated from very granular information, broken down by injection sources. Again, we had 2 patients, each with 16 sets of injections, had information on individual particle diameters from each patient. When those are aggregated, we have the effect given in the upper right-hand corner, where a typical mask, patient 1 is shown here, captures approximately 70% of the particles. On the ordinate is the proportion of the patient's particles captured, where on the abscissa is particle diameter. See that the capturing is greater for larger particles as expected, but in general, as I said, it's about 70% collected. Another way to look at that is to look at what's taken into caregiver 2A's airway. Now this is patient number 2. The caregiver is the one at his or her midsection. Again, on the ordinate is the proportion of particles captured. And in this case, this is all particles given out of patients 1 and 2 going into caregiver 2A's airway. And this plot in the bottom right-hand corner is particle diameters on the abscissa. And you can see that only very small particles make it to the caregiver, and of that, only 0.0002 of the original particles injected by or emitted by both patients are collected in caregiver 2A's airway. Another way to look at that same information is in the bottom left-hand corner, where the abscissa is no longer particle diameter, but it's particle volume, and it can be seen that essentially 0 volume is being ingested by caregiver 2A from both patients. We have much more data and animations available upon request, but in general, it looks like the masks are extremely effective. We are far from done with this work, and our future goals include the following. We'd like to consider design changes. Although this current design, the FelixOne, involves standard offerings in terms of oxygen mask and high-velocity nasal cannula, optimization is always a reality. We'd like to see if there's a better way to do this. Can the outlet of the mask, the discharge or the takeoff, be better aligned with the exhalation? Can the top of the mask be improved to reduce the leakage where we see the particles escape? Although they're small particles, but they're still escaping. And is there a better standard set of offerings available that would better meet this need? And can we employ higher suction rates with the available typical hospital resources? We'd like to consider other numerical and/or physical effects as well. We'd like to look at coughing and sneezing. We'd like to consider evaporation. We know that can be important. That's not been considered yet. We haven't had time for that. Also, we know that particle breakup, further droplet breakup, could be important depending on the ratio of the droplet size to the Kolmogorov length scale and the integral length scale, both at the top and the bottom of the inertial subrange. We'd like to consider that with one of our collaborative friends. And we'd like to consider the effect of the heat plumes coming from the body. If you have any questions, we'd love to hear from you. Thank you for your time.